السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. First of all, I would like to thank the scientific committee to give me the honor and the pleasure to stand in front of you today, and the organizing committee for the kind invitation. حفاظ الاستقبال كرم الضيافة جزاكم الله خير, and the chairman for the kind word of introduction. Without any further delay, this is I did it myself. Please excuse my illiterate ignorance in technology. If I would know, I would send it to the daughter of Dr. Hazmi to fix it. Anyhow, خلاص, you have to accept it. And by the way, I'm a full professor since February last year, alhamdulillah. Thank you very much. These are the objectives I'm given to by the scientific committee to talk about this disease. Let me start with this case which we saw in late 2018. Bangladeshi male, a lucky Bangladeshi male actually, diabetic, 59 years of old, who was on a leave in Bangladesh 3 months before this presentation, presented to our hospital with a history of 3 weeks of fever, cough, and respiratory distress. He was visiting another private hospital like 10 days before his presentation to us. They did a chest X-ray, found a cavity, and treated him initially as a community-acquired pneumonia. Then they put him in an anti-TB during hospital stay for 7 days or so, but he could not afford the expense, and he discharged himself against medical advice. And as they said, رجال تجارة, he knows a housekeeper Bangladeshi in our hospital who brought him to the ER. But unfortunately, he came almost comatose. Hypotensive, tachycardic, his saturation was only 88 in room air, respiratory rate of 50. And good, we have a policy to admit every critical case to a military hospital. So we admitted him. As you saw him in the spot, they intubated him. And his chest X-ray presentation was this. It's outlining the pathology most likely. There's a good cavity in the left, in the right upper. There's a bilateral inhomogeneous consolidation. There is a bit of effusion in the right side and the left side. And there's a huge pneumothorax as well in the initial CT scan. Anyhow, to cut it short, the patient was admitted to the ICU. We started numerical anti-TB, tazocine and vancomycin, treated him for good 5-6 days, chest tube for his pneumothorax. His condition did not improve initially. They took samples from everywhere, sputum and from the tab itself, and he grew Burkholderia pseudomeliae, leading to the diagnosis of melioidosis. Of course, because of the sake of the presentation, I can take it short. This took 2 to 3 weeks of intensive admission. Antibiotic were escalated to meropenem, and he improved a bit, and then discharged to the ward. Later on in the ward, he spiked another temperature with a little bit of cough, and his sputum grew aspergillus. And bronchoalveolar again done, and it grew aspergillus as well. There was a galactomanum. So this very unfortunate guy who has a melioidosis as the underlying disease, and most likely he acquired his aspergillosis during his ICU stay. However, antifungal and antibiotic were continued for a good 3 months inside the hospital. He was started initially in the intensive therapy, then the eradication therapy, and this is his CT scan and chest X-ray at the time of discharge. Unfortunately, because he's not eligible, we lost the follow-up of him in our clinic. But inshallah, he is doing fine. خارج يتكلم ويمشي. And we published this case. So, introduction melioidosis is an infection caused by facultative intracellular gram-negative bacterium called Burkholderia pseudomeliae. This organism is widely found in soil, water, and tropical regions, Southern East Asia and Northern Australia in particular. And the risk factors for severe disease include diabetes, alcohol use, chronic renal or lung disease, and occupational exposure to soil and water. This a timeline of the milestone of the history of melioidosis. The disease is very old. It's sitting with us for the last 120 years, since the first report of a case in Myanmar in 1911. In Southeast Asia, actually, it was reported like 15 years after that. The first animal cases reported in Africa 40 years after that, and the first cases in Central America, in Brazil, like a decade or 2 decades, that start to be reported from different parts of the world. And only till 1989, late 80s, early 90s, ceftazidime was started to be treating the patient and changed the mortality, really, since that time. However, outbreaks were reported in all areas of the tropics. However, there are sporadic cases outside the tropics as well. And with the advances of travel and the الكونسبت حق الترفيه الجديد الان people can travel everywhere especially للفار ايست محلات ارخص زي الفلبين تمام والامطار اللي هناك. I was discussing with Dr. Bukhari yesterday, Dr. Huda, and she told me she saw a case who went in a 3 weeks picnic and he came with melioidosis and he was in the rainy season in Manila or around it. So you may face a case. This is the only case I saw in the last 23, 24 years of practice in Jeddah. If we shift gear to talk about epidemiology, the top end of northern territory of Australia and the northern east of Thailand represent the hotspot, the hyper-endemic spot of the world, where they report 50 cases per 100,000 population. It is the third most common cause of death in Thailand after HIV and tuberculosis. And the disease is also considered to be endemic in Malaysia, Singapore, Vietnam, Cambodia, and Laos as well. There are other parts of the Southeast Asia where they reported cases in less number, but sporadic cases reported in Africa as well and in America. Estimated annual global burden is almost more than 160,000 cases annually, with the mortality reaching to 90,000 cases. This is the map of the distribution of the melioidosis. You can see the dark purple is the hyperendemic area, and the endemic area are the light purple, and the very light purple is the sporadic cases, and there are clusters over the world reported as well. This shows the map shows the area which they are certain of endemicity and certain of absence of the disease. Luckily, Saudi Arabia the disease is absent in our environment. However, as I told you, we can import cases, and with the change of the weather, especially the weather of Jizan now start to be like tropical, we may see this in the future. Okay, this is show the correspondence between the reported cases, hyperendemicity, and the mortality rate. The higher number of cases, the higher mortality you can see. Okay, melioidosis or the Burkholderia pseudomeliae are predominantly transmitted by percutaneous exposure, especially in the wet season, with exposure with the soil and the contaminated water. With the severe weather events, inhalation of the particles of the water, which may contain the organism, can transmit the disease as well. Ingestion of the unchlorinated, contaminated water could be another potential source of transmission. Person-to-person transmission is unusual, is highly unusual. The incubation period range from 1 to 21 days, with a mean of 4 to 9 days. Basically, the disease, most of it is asymptomatic or subclinical. However, severe clinical disease occurs mainly in adults with certain comorbidities, as we said before, diabetes, alcohol, chronic kidney or lung diseases. And among those symptomatic individuals, most present with acute infection within 2 months of the diagnosis. This is the pathogenesis of the disease. As we said, percutaneous ingestion or inhalation could be aborted of the organism, leading to most likely asymptomatic infection. However, if symptoms occur, it may cause bacteremia, and from the bacteremia, it can really disseminate to any specific site in the body to present basically the most two common organs involved are the respiratory system and cardiovascular system. In 40 to 60% can be pneumonia, complicated by pulmonary abscesses and pleuritis. In the cardiovascular, bacteremia resemble 40 to 60% of the cases. And bacteria without evidence of any focus can present in 10% and can cause pericarditis, mycotic aneurysm. And bacteria can disseminate the disease to involve the central nervous system as abscesses, to the urinary tract system as either acute pyelonephritis, kidney abscess, prostate abscess, to the skin as a parotid abscess or lymphadenitis as well, and to the gastrointestinal, it can cause abscess in the liver and spleen and paraintestinal masses as well, and in the musculoskeletal as septic arthritis, bursitis, or osteomyelitis. 80% those symptomatic people, 88% of the patient can present as an acute infection, however, 12% as a chronic or latent. In the acute infection, pneumonia can present more than the skin and the genitourinary tract. Bacteremia can issue as an acute manifestation of 50% and spread to any side, with a potential of septic shock in 25% of the patient. There is a high mortality rate of 10 to 40%. However, the chronic infection symptoms usually occur after 2 months. Majority of them present as a pulmonary sign and symptoms. It can be misled by tuberculosis or non-healing skin ulcer of atypical mycobacteria or abscesses as well. Chronic infection is more indolent than the acute infection. However, the mortality is low as 2%. The latent infection and reactivation only in 3 out of 1,000 cases, 3% of 1,000 in Australia, they thought it to be reactivation. And the longest time of reactivation was thought to be 29 years in one case, 29 years. How to diagnose the disease? Basically by the growth of the bacteria Pseudomelii from a culture of any site, which is the diagnostic method of melioidosis. On microscopy, they appears like a gram-negative bacilli, often has a characteristic bipolar. I don't know if it shows very well in there. Okay, with a safety pin appearance. Serological tests really are not very good, like the spotted fever. That's how it looks like in the different agars in the lab. You cannot differentiate it from E. coli in the sheep blood agar or the macroti. In the first 2 days, the colony looks like the non-fermenter. It is an oxidase positive enterobacteriaceae. However, after 4 days, which is a little bit long time for the diagnosis, the colony start to be wrinkled. And this wrinkling is really characteristic of the. However, in non-advanced lab, they have a very quick method since the inoculation of the disease to put a 3-disc test where they put aminoglycoside, colistin, and augmentin. And the gram-negative, which is oxidase positive, non-fermenter, resistant to gentamicin, resistant to colistin, and resistant to augmentin only. This is what the daily symptoms are. However, it has to be confirmed by the other culture. Luckily, we have a Vitek in our hospital, and Multitroph in other hospital, like in peripheral hospital and a hospital in a rural area, and in these poor countries, they don't have this advanced, so they have to depend in really a morphological diagnosis. So the culture of the B. pseudomelioidosis from the blood, sputum, abscess fluid, or pleural fluid are the definitive tests to diagnose the infection. And however, once you suspect a case, you have to notify a lab because it's a highly infectious organism. Lab should work it under safety cabinet too. and there was a lab reported cases, lab transmission cases in the technician. Other tests like a PCR, which is a rapid detection, however, it's less sensitive than the culture. And if you suspect anatomical site, you have to do a radiological investigation, including CT, ultrasound, to detect abscesses. And as we said, serology has almost no place of diagnosis. How do we treat this infection? There are two phases. The initial intensive therapy, which is composed of either carbapenems or ceftazidime. Ceftazidime works very well and it proved to reduce the mortality. And actually, it's not recommended if you have a CNS disease or a septic patient, critically sick, where carbapenems can be trusted more than the ceftazidime. Sometimes you may combine trimethoprim if you have a CNS or deep-seated prostate infection to perform the. This should be followed by an oral eradication phase of 3 months at least. Trimethoprim is the mainstay. However, doxycycline can be used, augmented in very limited cases, and you may combine trimethoprim to doxycycline for deep-seated infection as an eradication phase. Adjuvant therapy can be used as well. Human granulocyte colony-stimulating factor is suggested sometimes and can help to early eradication of the disease. And in non-pulmonary organs, ceftazidime can be trusted alone. However, if you have a CNS or septic arthritis, osteomyelitis, you may need add trimethoprim sulfamethoxazole. The prognosis before the antibiotic therapy, or if there is a delay, it's very bad. It may carry a mortality of 40%. However, after the effective antibiotic therapy, this reduces to less than 10%. However, if you have a bacteremic patient or high-risk patient like diabetic or renal failure, the mortality can be higher. Most death occurs in people with diabetes, excessive alcohol state, or renal or chronic lung disease. Unfortunately, there is no vaccine available. There are studies in the marine and in animals. And there is one study in phase 1 in a human, but still none have really shown any commercial use yet. The main preventive strategy is avoiding exposure in endemic areas with all the the precaution, how to avoid soil, water, and during severe weather events you have to avoid going outside, which is sometimes it is the main purpose of a trip to those areas. Okay, these are my references, and thank you very much.